I think it's live, Mruti. I can see it on my side.
So it's live.
Yes, can I'll just mute the Zoom and just see if I can hear the voice from the other one because I'm using one device here. It's live. I can see it there.
Oh, okay. I wonder why you are not the owner.
Fine, Mruti.
Is the voice fine? Is everything fine?
Yeah, everything is fine.
Oh, okay. So today we are live on YouTube.
Today you are live.
Why you are not the owner? Can you write something here or share a link? How do I do the sharing of a link?
Share a link for that. Okay.
For YouTube.
I'll just I'll just share it now.
Maybe, Pastor, can we check the presenter? Can he present or share screen in the meantime? Maybe can we test that one?
No problem. Greetings, brethren.
Greetings, greetings.
Okay,
Let's test yours and yours. Yeah, let's
let
test
me
yours.
just share the presentation. Okay. Share the presentation. Okay.
Why didn't you ask me? It's okay, man. Nothing.
Is that fine?
That is very fine. I can see it on my side. So even the sound, your sound, it's still fine. So thank you.
Okay. Thank you, sir.
Even on YouTube, is it fine?
Let me check the YouTube. It is fine, Pastor. It is fine. Even the sound, when you're asking, it is fine as well. It is showing also on YouTube.
Yeah, it seems we are ready to go.
It is 4:05. I think we can go ahead and start. It is 4:05. At Dr. Tshabalala, is your audio still fine? Dr. Tshabalala?
Yes, sir. Greetings, sir. My audio, I think it's fine. Can you hear me?
It is very low. I don't know if it's just on my side, but it is very low.
No, it's on your side. I can hear him loud and clear.
Okay, if we
Thank
can
you.
hear, then that's okay. You are here. I think let us start. We can start with a word of prayer. Can I ask the president from the Platinum District, Brother Panache, can you pray for us as we start?
Okay, let us pray. Precious, kind and loving Father, what above, Lord, to thank you for the privilege you've granted unto us. Thanking you for the time that that you have given unto us, so that we can gather here and be encouraged onto how we can deal with kids. Please bless us abundantly and make sure that everything that we're going to be taught can bear fruits in our minds, and we can be able to utilize it, so that we can have an easy time dealing with kids and their challenges. I pray all this in the mighty name of our Lord and Savior, Jesus Christ. Amen.
Amen, and thank you, sir. Amen. We welcome everyone that made it today. Me especially, it is my birthday today, and I'm here doing the work of the Lord. So we welcome everyone that has joined. We thank you for joining. It is a junior youth corner that we are intending to have most Sundays. So thank you for joining. The topic for today, it is mental health, and it will be presented by the doctor, Dr. Tshabalala. I think, yeah, maybe when you start speaking, sir, you may further add other accolades to the name. The presenter today is Dr. Tshabalala, and I think when you are ready, over to you.
Thank you so much, Program Director. My name is Tshabalala, and just a little bit of a background. I am a physiotherapist by profession, and I'm a senior lecturer at Sefako Makhato Health Sciences University. In the ministry, I'm one of the federation members of Ebenezer District, and the office that currently I'm holding is that of being a president. Yeah, I think that's about it for the introduction. Now, our talk today, I just want to say mental health is a very broad topic. And today I have restricted myself to material that will help us to understand mental health of children and young people in our church. And I hope that leaders, as we are here, we will also have an understanding why children end up consulting healthcare facilities like hospitals to seek for mental health interventions. So, yeah, as we go on, our talk overview, the main aim is for us to recognize the role that healthcare professionals or hospital staff are already playing in supporting children and young people's mental health, and also to develop an understanding of common mental health difficulties, to explore the different scenarios where you support children and young people who may be experiencing mental health difficulties within your clubs, and also within the churches, because sometimes there might be young people who are not necessarily a member of the Adventurer Club or Pathfinder Club, but we may be interacting with them through the Children Ministries Department. And if we understand, we are in a position to support the child and support the family better. Also, the aim of our talk today is to also understand the experiences of children and young people, and to explore and understand how to communicate effectively with children and young people with mental health difficulties, and to explore and understand key approaches to support children and young people who are in the junior youth ministry. And let me add to say it is not only children who experience mental health challenges, but also anyone, irrespective of age, can experience mental health challenges. So today it's all about breaking the stigma and having this talk that we are going to share together. And I understand that we are on a journey. Some of us, we are master guide trainees, and some are master guides, and we really need to know about mental health. However, let me be quick to say, to understand mental health better, there are specialists who deal particularly with this subject, and the various specialists that deal with it, one of the sources that are used mainly is the Diagnostic and Statistical Manual of Mental Disorders. Currently, we are on DSM-5 TR, and the 5 stands for the 5th edition, and the TR is for the text revision. So before this, around 2013, we were actually on the DSM-4. So you can see we moved from DSM and we moved to DSM-2, DSM-3. Right now we are on DSM-5, and it's really a sizable volume. It's very big. And this volume, it's written by different psychiatrists, medical doctors, psychologists, and other contributors who are specialists in mental health disorders. And they have actually categorized the different types of mental health disorders to ensure that anyone with a mental health disorder receives an accurate diagnosis, and over and above receives an accurate intervention, or an intervention that will be effective in managing their condition. Now, the World Health Organization says health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, there are lots of what I call jargons here, which if we decode, we say, you know, when you are healthy, physically, your body should be completely fine. That's the physical part. It's about the anatomy and the physiology. The anatomy, the body structure, the bones, the muscles, and so on. And also the mental, which has to do with the brain. And we know that the brain is very complex, because within the brain, we also have the different parts of the brain that are responsible for different, what we call executive functions. But also, interestingly, health has to do with our social well-being. If we are not socially well, if we are not able to socially integrate in our society, in our community, at school, in the class, at work, in the home, in the family, it means that there will be a problem, and that could actually mean that we experience ill health. So I will just repeat to say health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And by infirmity, we could actually say also disability. Now, let's have an overview of mental health. One may ask a question, what then is mental health? The WHO, the World Health Organization, defines mental health as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. And this definition is very, very comprehensive because it talks to an individual realizing their potential and an individual being able to cope with the normal stresses of life, and an individual being able to work productively and fruitfully and being able to make a contribution to his or her community. Now, some of the terminologies that I would like us to keep in mind as we talk about this subject of mental health is mental health itself, which is an overarching terminology or an umbrella terminology under which mental health problems and mental health and well-being sits. And mental health difficulties is a term that refers to symptoms that meet the criteria of clinical diagnosis of mental health problems. For example, anxiety disorders, depression, eating disorders, and there are many others, including, among others, communication disorders, behavioral disorders. The list is actually just too long. Now, mental well-being, when we talk of mental well-being, is a term that includes self-satisfaction and how we feel about ourselves, meaning our self-worth, our self-confidence, control that we have over different situations, adversities, etc., purpose, a sense of belonging, and being able to form positive relationships and experiencing them well. Now, what is also key is to understand that mental health has to be referred to as a continuum. And this means that it is a continuum on a spectrum. It can start, let's say, maybe from the time a child is born, when they are not able to communicate like we do in terms of speaking, but they communicate through crying, all the way through to old age. And that's the continuum. Now, why prevention is important? Because when we know about this, prevention, therefore, is extremely important. So why is prevention important? In this case, prevention is important because 1 in 10 children, they generally have no one to talk to in school when they are worried or sad. And nearly 4 in 10 children, when they were interviewed through some research that was done, they found it difficult actually, going through sleep. And more than a quarter of children, about 27%, said they got into fights or arguments. And when one checks, these children actually have got mental health difficulties. And more than 1 in 4 children said that it caused them to struggle to do their homework. And more than 1 in 4, they didn't want to be around other people. And let me just maybe stop here and say some of the challenges that children with mental health difficulties will have. They will not, for example, be able to stand their peers. They will not be able to stand crowds. They may actually have different types of phobias, including noise or certain sounds, and so on. And those are challenges that makes it difficult for them to interact with their environment and more so also to interact with others. Now, 50% of mental health problems are established by the age of 14, and by around 24 years of age, 75% of mental health problems are actually diagnosed or established. What we also need to note is that adverse childhood experiences have been found to have a lifelong impact on mental health. And we will see some of these adverse childhood experiences. Now, children born into poverty are more likely to also experience mental health problems. Now, in a public health study done in Scotland, 2021, they found that education is important for well-being and can impact on many outcomes in life, such as mental health. And I believe that the curriculum that we have in the junior youth ministry, the curriculum for adventurers and the curriculum for pathfinders is a well-structured curriculum that also impacts on many outcomes in life and similar to schooling. What is also important is that 20% of adolescents may experience a mental health problem in any given year, and about 10% of children and young people aged between 5 years to 16 years have a clinically diagnosed mental health problem, yet 70% of children and adolescents who experience mental health problems have not had appropriate interventions at a sufficiently early age. So some of them are actually picked up right into adulthood when these problems have actually been settled and they are actually more difficult to control or to manage. What is also important, coming from the American Psychological Association in 2016, is that 83% of people will experience a mental health problem in their lifetime. So let's think about it. It simply means more than 1 in 5 people will experience a mental health problem in their lifetime. And today, what I just want us to do is to have an understanding on identification. And here we can see that 50% of lifetime mental illness, excluding dementia, starts by age 14. And this is actually a very significant number. When we talk about dementia, it's a special mental condition that has to do with forgetfulness, and particularly we see it more in the elderly. There are other causes of dementia, but it is not for our talk today. And what we also see is that in the mid-20s, 75% of lifetime mental health or illnesses, they start around the mid-20s. And I just want to share with us a clip that will summarize this whole concept of mental health and help us to have an overview that I have actually tried to express. And I think this clip from a hospital summarizes it very well for me.
You know that feeling where your thoughts scare you or make life tough? Sometimes it feels like no one else in the world has those thoughts or feelings. No one seems to know how difficult it is to deal with your feelings. And it's not easy to share your deepest secrets. You might think something is wrong with you. Or you might worry what other people think. And all of that makes your thoughts and feelings worse. Our culture has created this environment of shame. Until the 1960s, society sent people away if they had challenges managing their thoughts, emotions, and behaviors. Over time, we learned that we didn't have to be afraid. We learned how to help people get better. We became hopeful. But there are remnants of those images in our culture today, which is why some people still feel uncomfortable talking about it. The stigma has taken new forms too. With more access to more people all the time, it can seem like the world is telling us it's not okay to be anything but perfect. The truth is, everyone has thoughts or feelings that can be hard to deal with. So why do we make it so difficult on ourselves by judging others who could be going through the same challenges we are? What if, instead of seeing labels, we saw people who are struggling and could be there for them so they didn't feel so alone? What if we looked past our fear of mental health and started to talk about it in a constructive way. What if, as a society, we used empowering words and healthy images to help people feel supported? Maybe then more of us could feel comfortable telling others when we're having a hard time. Maybe more people would get the help they need. And maybe one day we won't have to talk separately about mental health and physical health, but just health. The truth is, each of us has the power to change our culture. Will you join us? Share this video with a kid, your neighbor, a friend, and help us break the stigma of mental health.
I am sure that from this video, we begin to understand how important it is to actually break the stigma. And now, as part of our discussion, as we continue with mental health, I would like us to consider this question. What can affect the mental health of a child or a young person? Maybe at this stage, I can maybe open for not more than 2 hands to hear what leaders on the platform think about mental health and to also break this thing of me alone talking. Is there anyone who would like to share? Yes, you can unmute, please, my leader, and just share. This is a chance.
There is no hands up yet.
Okay.
Okay, there is a Mashiti show. Sorry for saying it wrong. You are muted.
Yes, good afternoon, colleagues.
Good afternoon, Doc.
No, not now. I'm a student.
All right. Okay.
One of the things that can affect a child's mental health is the environment in which they are growing. For example, if they are growing at home and there is always disorder, disharmony, there's no peace, there's always shouting, there's always fights, that can negatively affect the child's mental health. Thank you.
Absolutely. Absolutely. Thank you so much for that contribution. One more. One last contribution. Okay. In the absence of any, absolutely the environment can. And what we also see is that what can affect children and young people's mental health include adverse events of life, like, for example, bereavement. And when a child goes through bereavement and grief, they may actually experience serious mental health challenges. Another one is actually divorce or separation of parents. Children don't know how to actually regulate or control what they feel and express themselves. And because of that, they may also experience mental health challenges, including issues of imprisonment, bullying at school or in the community, even long-term illness, issues around physical abuse, a child that is constantly abused at home, sexually abused, issues of peer pressure, school pressures, and if a child is carrying responsibilities that are actually above what a child should carry, they may also experience mental health challenges. And among others, addiction can be another big challenge that lead our children to experience mental health challenges. So now, leaders, in our clubs, in our churches, what should we look for? And of course, it's not just about tick boxes, but these are some of the things that we should look for in the children that are within our vicinities, children that are within our care, be it in the children ministries class, or just in the church in general. We should look for signs that show that the child is withdrawn or where the child is experiencing loneliness. We should look for decline in school performance. It could be a sign of mental health difficulties. Sometimes we can see the physical appearance. For example, children with Down syndrome, they have a peculiar physical appearance, and a significant percentage of children with Down syndrome, they do experience mental health difficulties. Another thing that we should look for is children who all of a sudden become aggressive, and children who are risk-taking, and sometimes children who experiences changes in eating and sleeping habits. Sometimes we can see self-harming behaviors in children, and at times there could be absenteeism from school or from the youth club, and they are no longer, coming as regular as they used to. Sometimes they may experience lack of joy or interest in things that usually they used to enjoy. And at times our children may have very low self-esteem, very low confidence, and a sense of self-worth that is very, very low. For example, when you are in a club, you may find that when a child is given a task, maybe to recite a verse or to share a story, if any of the children starts giggling or talking, they may actually completely lose control, and they may start crying and not wanting to participate and showing signs of apprehension. And those are some of the signs that we should look for. Another one is when children show communication difficulties. So these are some of the things that we should look for. And particularly if you pick up about 3 of these observable signs, we should communicate with the parents, and where possible also advise that maybe they can seek medical intervention. Now let's talk about some mental conditions affecting children and young people in our church or in our clubs, in our homes, or even at school. And today I'm just going to talk about the common ones that are generally there. Now, the first one is about defining depression. And when we define depression, in short, in simple terms, is when we get stuck feeling down. We just feel down and we feel stuck, that we cannot do certain things that we used to enjoy doing. We lose interest. That feeling of being stuck, in short, could actually be depression. And with depression, medically, it is classified. It can range from mild, moderate, to even severe depression. Some of the depressive symptoms include continuous low mood or sadness. And there are lots of other mood disorders, what we call mood disorders. And at times, what we also see is that the child may have the symptom of avoiding contact with friends, not being motivated or interested in things. They have loss of pleasure, having thoughts of harming themselves, or even having what we call suicidal ideation. These ideas of suicide, or sometimes they say they hear voices that are actually telling them to end it all. And sometimes they just have this feeling of being tearful all the time, lack of energy, poor self-care and self-image. And even for those who are adults, it could even be low sex drive. There could be more or less sleep, meaning that one could sleep for longer than normal, or they could have disturbed sleep and they only sleep for short periods. They generally, what people refer to as catnapping, throughout the day and even at night. They don't have sleep. and so on. They have a sleep disturbance. And at times, it could be a change in diet that shows that someone is depressed. They may be eating more junk food and things that actually they know that they shouldn't be eating. And the other one is unexplained physical symptoms, including generalized body pains and aches. These are some of the depressive symptoms. Now, many people use the word depression, or they say someone is depressed, to describe their mood when they are not talking about a clinical depression. And it is normal for everyone to experience periods of sadness or low mood following trauma or other negative life events. Now, these symptoms, tick lists, can give us some ideas, but understanding the impact of their mood on the child or a young person is extremely important. Now, another one that is common is anxiety. Now, when we define anxiety, we say it's when our worries get in the way of our life, and we worry about things that are yet to happen, which are not here. That will cause us to have anxiety. Now, there are different types of anxiety, and the common one, especially for some children when they start school, they may experience separation anxiety. And some children, when they are brought into the club, you find that the parent wants to just, leave the child in the adventurer club with their peers. And as soon as they want to leave, the child may experience separation anxiety, not wanting to separate with the parent. And that's why in most cases, we encourage that parents should be part of the classes and they should be with their children, particularly in the adventurer ministry. The other thing that is very important as another type of anxiety is what we call generalized anxiety disorders. And some of these could include, for example, someone who might have had a car accident in the past over a year or so. When they are in a car that is driven by somebody else, if they are not driving, they actually have an anxiety disorder, and they panic and they feel their hands are sweating and they feel their heart rate is beating fast, and they even have these thoughts that are racing in their heads and they feel unsettled. That could be a generalized anxiety disorder that is related, for example, to that specific scenario of driving. Another one is social anxiety. There are people who, when they are supposed to meet with a group of people, let me give an example. If we say there are visitors who are coming at home, a child may actually start feeling social anxiety when there are lots of people who are coming into their space and they don't really want to be with people. They want to lock themselves away. They feel very uneasy. And there are also specific phobias. These are general types of or different types of fears. Like some people have got fear of darkness. And we know that load shedding has actually led to some people developing different types of anxieties, because some people might have experienced crime during those periods of load shedding. And so they tend to actually develop fear of darkness as a specific maybe type of phobia. Others include panic disorders. And the other one, another type of an anxiety, is an obsessive compulsive disorder. Now, what are some of the symptoms of anxiety? Some of the symptoms may include feeling nauseous, feeling shaky or dizzy, experiencing a rapid heart rate, changes in breathing rate, and you find that now someone is breathing fast and shallow, feeling butterflies in the stomach, having poor concentration, feeling worried, being upset to a point that, sometimes people shake when they are upset or tearful, and others become highly irritable, and others avoid situations, feeling tense and having tension, and at times experiencing distress about normal tasks. This could be symptoms of anxiety. Now, it is normal for all of us to experience different types of anxiety during our everyday life. There are benefits to experiencing a normal range of anxieties, like, for example, when one is preparing for exams, when you know that the exam date is coming closer, you become anxious, and it could actually be the drive that you need to actually work of that positive anxiety. You actually study hard and you are still able to control your sleeping at times, and you are able to actually remember the things that you have studied, and you pass the exams. Others may include road safety and so on. All right. Another type that is very important is that there is a huge overlap between the physical and emotional symptoms of anxiety and all mental health problems. So at times when one is anxious and experiencing these emotions, you may find that also the physiology of the body, the way the body operates, it actually sympathizes with the mental strain that the body is going through of anxiety. There is also a huge overlap of symptoms between different mental health conditions, making it tricky to identify exactly what is going on. And that's why it's important to consult healthcare professionals and for us to avoid labeling children or anyone with a mental health difficulty. Now, again, the symptom checklists can give clues to explore further, but recognizing the interference in someone's life and their level of distress versus other children and young people you interact with is key in early identification. So as a teacher, a master guide trainee who is in a class, as a counselor, you may be able to identify that there are some tick boxes that the child actually meets, and you may want to discuss that with the parent and advise that, you know, if possible, there should be some other forms of intervention. Now, another type that I just want to talk about is bipolar disorders. And when we define bipolar disorders, we define it as swings between extremes of depression and mania. And what it means is that this word bi, it, you know, when we break it down, it also means two. And then polar disorders, it talks about our polarity as well. And I'm oversimplifying this just for the sake of, you know, just us understanding. It simply means that someone can swing from being extremely happy and experiencing high energy and being optimistic about life and the future to being really depressed, being very optimistic, not wanting to meet anybody and just wanting to be left alone. And that swing between those extremes, when it lasts for a long time and it is actually interfering with our day-to-day activities or tasks, there is a need for intervention. And like I mentioned earlier, the best place to consult is the healthcare professionals. The family doctor, the family physician can be very instrumental. There are also nurses who can assist in the primary healthcare centers like the clinics in our communities. There are psychiatric trained nurses, and they are able to actually assist, and they can refer the patient to the healthcare team that can actually give the best intervention. Now, what are some of these mania or manic symptoms? It's someone who is incredibly happy or experiencing a high mood, having rapid speech, and when they feel that, you know, they are not speaking fast enough, and at times they've got increased talkativeness. At times they have racing thoughts, and they feel that their thoughts are actually faster than they are trying to express them. And at times they're experiencing restlessness. They've got difficulty in concentration. They've inflated ideas about themselves and their abilities. And at times they're not looking well after themselves. They don't bath as regular. They feel that, you know what, we only bath when we go to church, as an example. Or we bath only when we go to town, as an example. And at times they may have lack of sleep. Sometimes they may be overspending, spending the money that they shouldn't be spending, and having other reckless behaviors. Now, increasingly, the word bipolar is used in everyday language to describe ups and downs, mood swings, or emotional dysregulation. Now, bipolar and mental illness in general is often portrayed negatively, particularly in the media, or is associated incorrectly only with violence, as it is documented in Time to Change. Unlike mood swings, manic and depressive symptoms can remain stuck for several days, weeks, and they don't necessarily need to follow an up or down pattern. So you may find that for a number of days, someone is feeling manic, they have such high energy, and for a number of days or even weeks, and all of a sudden again they experience a dip and they have a depressive episode. Now, 1 to 2% lifetime prevalence of bipolar disorders is actually seen particularly in the UK versus a 20% lifetime prevalence of depression. What this simply means is that when it comes to bipolar disorders, it is less common. It will affect about 1 to 2% of the population at a given time, compared to depression, which can affect up to about 20% of people at a time. And there is what we also call psychosis. And by psychosis, it simply means an altered state of how we think, feel, see, and act. Another common, simple definition of psychosis is a clear break with reality. So it's if someone is living in their own world and they are, they are not experiencing the reality that an average human being will experience. And we will say that is psychosis. Now, what are some of the psychotic episodes? Is seeing or hearing things that aren't there, having false beliefs incompatible with society or culture, and sometimes having ideas of grandeur. And these ideas of grandeur, for example, it's someone who feels that, all of a sudden they have all the powers in the world. If they say something, people will do exactly what they say, or they feel that when people are doing whatever they are doing, it is because of their own powers. They are the ones who are giving them powers to execute the various tasks. And also feeling more important than everybody else. That sense of, grandiosity. And sometimes also it includes feeling they are being persecuted, and thoughts where they broadcast their own thoughts. That's broadcasting of their own thoughts all the time. And at times, it could be thought control. They feel that they don't have any control over their thoughts, or they feel they have too much control over their thoughts and they're not going to say anything to anybody. They're just going to keep quiet. No matter what happens, they're not going to talk. And it appears as if they can't speak at all. They've lost a sense of language completely. It could happen. And sometimes it's about mind reading, and it's both ways. They feel that they can read other people's minds, and sometimes they feel that as they are seated, people are able to actually read their minds. People know exactly what they're thinking, and they feel very uncomfortable, and they have that clear break with reality. And at times they have incoherent speech. Now, when we are defining psychosis and understanding it, it is important to note that each person has a unique experience and combination of symptoms. And more than 3/4 of men and 2/3 of women experience some episodes of psychosis before the age of 35. And when one wants to ask questions about psychosis, it is important to consider the following 4 important points. 1, consider normal childhood development. We know that children, when they develop, there are what we call normal trimesters of development. From birth up until maybe they are a year old, or sometimes until they are toddlers. And it could include having an imaginary friend or understanding your internal voice, which can be more difficult for children with social or communication problems. Another one that we need to consider with psychosis is issues of faith or religion. When people say, for example, they are hearing the voices of God and they have heard God telling them to do this and do that, it could also be a sign of psychosis. And also the effects of alcohol and drugs. And let me quickly just share this one with us leaders. Our children are under severe pressure to taking and experimenting with alcohol and drugs. And it will do us good to actually understand this problem and to actually address it with them in an environment that is conducive. And that conducive environment needs an understanding adult who will be able to actually listen to the child and try to understand the root cause of this alcohol and drug consumption in our youth. And the 4th one is other illnesses or physical complaints, such as, for example, head trauma. When a child maybe was playing soccer and they fall down, they experience what we call a concussion. And maybe coming out of that, or when they are playing certain games and they bump their head against something, they could actually have some physical complaints. The other thing that one may need to consider is UTIs. And these are, among others, some infections, which are, maybe we can even say, urinary infections. They can lead to some form of psychosis. Like, for example, syphilis, which can cause neurosyphilis. It may present with psychosis, among others. Okay, and the other one is tropical diseases, and there are many other different types of illnesses. So when one is trying to check and find out what is happening, some of the questions that may be asked may revolve around these issues of normal development, faith, issues of alcohol or drugs. And under drugs, we also include prescription medication. At times when it's overdosed, it may actually make the child to experience certain symptoms. And at times, some of the medications, some of the drugs, their side effects may lead to maybe even hallucinations, where a child starts hearing certain sounds or feeling in a certain way. All right. So it's not just illicit drugs. It could also be medications. And that's why it's important to actually store medication. And maybe let me pause here and say, especially at camp, we need to be very careful when our children are camping. At times they will buy cold drinks like Coca-Cola or Sprite because they know we don't want Coca-Cola, and they can mix it with certain medications and creating a drug, particularly codeines, different types of codeines, like these are the cough mixtures. So if a child mixes a cough mixture with Sprite, it could actually be a drug. And at times, mixing things like simple allergics, that's a liquid form, that's a tablet. If they mix that with Sprite, it could actually be a problem to a child. So these are some of the things that we need to just be aware of. And when we speak to young people who have experienced psychosis, they tell us it's important to help for staff to, number one, to acknowledge the experience and connect with them emotionally. So they feel more comfortable when there is someone who is willing to listen and to hear them. And they say it's also helpful for staff not to pretend. So we don't have to pretend you are experiencing their reality. We don't experience their reality. We shouldn't, pretend that we are experiencing what they are going through. And they say it's also helpful to validate their distress without colluding or backing up their abnormal experiences. And also don't assume they won't be able to make any decisions about their care. And this is very important, especially for healthcare workers. It's important to also discuss the interventions with the child. We shouldn't just assume that it's a child and therefore we are going to treat the best way that we know how. It's important to just, involve them in the decision making. And also, young people say it is most helpful for staff to allow young people, they say they remember people who made them feel safe or who were nice, even when they can't remember what the person said or did. So that experience when they were sick, they will remember how they were made to feel. So it's very important for us leaders that when we are in our club, whatever the condition of our child that is in our club, we take interest in them and we make time for them to listen to them, to make sure that they are acknowledged, they are validated, and we involve them in decisions. We check with them if they understand the task, and we go an extra mile of showing them at times what needs to be done than just, expecting them to be like any other child and doing the task by themselves. So that feeling, they will remember it for a very, very long time. And some of them, it's what may make them to want to come to the club and even come to the church all the time. Right? And there are some physical symptoms that may not be explained. And these are physical symptoms we do not understand. And how do we define some of this? Our physical health generally responds to our mental and emotional health in a normal way because the brain is part of our body. And what is important is that we accept certain physical symptoms as real. Like, for example, when you are experiencing sweaty hands and when you are experiencing butterflies in your stomach or an upset stomach, like, for example, when even with myself at times when I'm a bit anxious, there may be times where I feel I need the bathroom, I need to sit, or I feel that my stool is a bit loose. And it's normal at times to experience that. But there are other more extreme physical symptoms that are often subject to disbelief and stigma. And when we experience those, it may actually be a sign that we need intervention. Now, don't forget, history of diagnosing issues as mental health problems when they are physical causes, like, for example, epilepsy. And someone saying, epilepsy is a moral condition, it's actually a problem. All right. So there are different causes of epilepsy, which can be medical. And even the types of epilepsy, there are different types of epilepsy. And therefore, it's important to just note that, we cannot just classify that as just a common mental health problem. Now, medically unexplained symptoms, they present a challenge to services as most physical and mental health systems are set up to work separately, often resulting in lengthy periods in their service until an alternative approach is sought. And this means that at times we tend to separate between the physical and the mental illnesses, and that creates the stigma that we actually need to break. As you saw in the video clip that I played at the beginning, that, there's a time where we need to stop labeling. And even children, we shouldn't label them, especially when they present with mental health difficulties. We should just see that as a health problem. Now, remember that there is still a huge amount of stigma about mental health, and so many people would prefer to have a physical health problem rather than a mental health one. Like, for example, when people are sick, and they have gone to consult a doctor because of a flu, they are quick to tell others that, you know what, I've had a flu. But if someone has been diagnosed with a depressive episode and they are told that they've been admitted for depression for 3 weeks at the hospital, they don't even want to tell people that they were hospitalized because of depression. So it is important for us to have positive communication about the role of mental health professionals in supporting physical health symptoms, and it can make a big difference in how care is actually received. And we need to be open-minded about physical or emotional cause, but we don't always assume the symptoms relate to trauma. And during childhood, adolescence, and young adulthood, our brains are still developing and making connections. So here we are talking about the neural connections that the brain is still making. And some of these neural connections, they can actually be chemical in nature. We are producing different types of neurotransmitters that enable us, for example, to store certain memories and so on, and to enable our brain to communicate our various activities better. And there is a lot we don't know about how our bodies and our minds interact. And as a result, we may be experiencing some of these unexplained physical symptoms. Now, within mental health, we have eating disorders. And the reason is that we all have a relationship with food, and some of us more or less are aware of the relationship depending on our personalities, interests, and dietary needs, but we all have a relationship with food. And most of us will also experience supporting someone who was in a dysfunctional relationship with and may support them. And same with food, we need to support people, all right? And we recognize that we are unlikely to be able to act on our advice to just leave them, but we can play a supportive part in their journey when they are experiencing an adverse relationship with food. And the same is true of a young person with an eating disorder. We might not be able to direct the change we want to see, but we can play a supportive role on their journey. Now, what are some of the dysfunctional relationships that young people may have with food? There is a difference between diet and a disorder, an eating disorder. And particularly here, we talk to restrictive eating disorders. Sometimes there may be a denial of diet. There may be also a denial of hunger and craving. There may be an increased interest in food. They may actually be eating slowly. There may be ritualized and compulsive behaviors around food. There may be new or increased exercise routines. There may be change in food rules. All of a sudden, they don't mix this and that, and they don't want this before that. They don't tolerate certain textures. They've, that kind of food rules. Covering up for weight loss, claims of needing to eat less, avoiding eating with others, socially being isolated and experiencing low mood, and biological changes. Like, for example, particularly in women, they may experience that their periods have actually stopped when they're eating certain types of food. It may be associated to eating disorders. Now, eating disorders are not just about weight loss. People can maintain a normal weight and still have an eating disorder, like, for example, in bulimia nervosa. And another one, and bulimia, it's mainly when people are just overeating. And it's a complex psychiatric disorder that requires proper assessment and intervention. At times also, anorexia nervosa has the highest mortality rate compared to other mental illnesses. And this simply tells us that, we can take eating disorders for granted, and they can be fatal. They can lead to fatality. So many eating disorder services are not set up to manage compulsive overeating or binge eating disorders. And with these conditions in children often being seen in the public health, we realize that healthy eating becomes a serious problem. So understanding mental illness, as we wrap up, mental illness is not just a tick box exercise. And mental health is still a young field with many answers about what works and doesn't work or what causes people to become unwell, still under research. And supporting the individual and responding to how they are feeling and acting is essential to providing high quality care. There is a myth about violence and mental health. And what is important is that people with mental health problems are 5 times more likely to be victims of assault. And at times, it's rising to 10 times more likely for women with mental health problems experiencing assault. And we hear from talking to hospital staff, however, that they remember these incidents more because they felt out of their depth in managing the situation versus when the child, they're just kicking out without having a cannula. So what we need to understand is that all people with the same diagnosis will appear, act, and feel and respond differently to you. And it might be helpful to consider the following when there is a question on the presence of mental illness. We need to check impact on everyday functioning, check rapid deterioration in any area, disengagement, significant change in behavior, risk to self or others, and bizarre behaviors, beliefs, and symptoms. Now, we may also need to understand communication, behaviors, and disorders. What is important here with behavior is what we see when a child shows some different types of abnormal or what we regard as odd behavior. And what is important is for us to note what drives our behavior. And this is what we can see, like the underlying feelings, motivations, worries, thoughts, and basic needs. And sometimes children, they show certain behavior because of these underlying feelings. So it's important before fighting a child and just kicking them out of a class to try to also follow up and understand what could be causing them to behave in a certain way, because it can help us to intervene. Now, choose one behavior you find difficult when supporting a young person with mental health difficulties in your church, or maybe if you are a healthcare worker in your clinical practice. Think about the young person. Ask yourselves, what do you see or notice? How does the young person act? What do they do? Try to imagine how the young person might be feeling. What might some of their underlying feelings and worries be? What are their core needs in this situation? It's very important to go through this exercise because it helps us to understand what the young person may be going through. And then what we like you to also do is to choose one behavior. It's just that, we have time constraints. We may not be able to do this exercise fully. But what I want to emphasize is that you may choose one behavior you find difficult when supporting a young person with mental health difficulties in your church or in your clinical practice if you're a healthcare worker. Now think about what this is like for you. What are some of your underlying feelings and worries when you're observing this child? How might you be acting? What might be the young person see, or what might the young person see or notice? And what are your needs in that particular situation? Now, regardless of which mental health difficulty a young person is experiencing, they have core needs like all patients. Their behavior is not just a product of their mental health issue. Behavior is a form of communication. We need to try and understand what they are trying to express. Now, young people are individuals. If we have 10 young people with the same mental health difficulty, they will all have different underlying feelings, worries, and wants. This is why it is important to understand and respond to underlying feelings, core needs, rather than the visible behavior and making certain assumptions about their behaviors. Now, all children and young people have the same core needs, which is exactly what healthcare workers are skilled and experienced at supporting. And what we are saying to us here as leaders is that you don't have to be an expert in mental health to be of help. We can assist our young people in our clubs, in our churches. Now, just a quick exercise. If you are able to raise your hands, using the icon, using the actions, I would like us to do exactly that. Now, hand up for harm. What I want you to do, leaders, is to listen to the following scenarios. And if you think the behavior or situation that is described is an example of self-harm, I want you to raise your hand. And here, of course, there are no questions. We don't ask questions or we don't allow, a discussion. So let's go for it. A 15-year-old breaks a bottle and cuts their wrist with a glass. When you think of this scenario, do you think this is self-harm? Yes, I can see a hand. Pamela and Sibu, yes, I'm seeing the hands, leaders. Yes, I'm seeing the hands. Indeed. Okay, let's move to another one. Thank you so much. We can drop our hands. That's another scenario. A 13-year-old inhales paint fumes in a shed, or maybe in a shack, or in a house where they are staying. When they inhale this, is this a sign of self-harm? I'm seeing one hand. Okay, I'm noticing those hands, leaders. Another one, you can maybe put your hands down. Let's see. Let's put our hands down. Thank you, leaders. Another one. A 17-year-old jumps off a building and breaks their leg. They can see it's very high. Is this a sign of self-harm? Okay, I'm seeing more hands. More hands. Yeah, I'm seeing those hands. Thank you, leaders. And maybe we can put our hands down. Another one. Let me wait for the hands to go down. Okay, let's put our hands down. Thank you, leaders. Let's go for the last but one. A 14-year-old bends letters into their legs. So they receive these letters, they take them, they bend them such that, even their feet experience some pain. Is this a sign of self-harm? I'm seeing the hands. Yes, I'm seeing the hands. Okay. And another one. We know now there is load shedding. There are generators in the health facilities. And you have a healthcare professional smoking cigarettes by the generators, close to the generators. Is this a sign of self-harm? Okay, so yes, I am seeing some hands. Thank you so much, leaders. Now, in the interest of time, we are just about to wrap up. But, I will have said in the interest of time, what is it that you want to know about all these scenarios? I can allow maybe one person to make a comment before we move. Is there anyone who would like to comment? Maximum 2 people, please, leaders. You can unmute. You are allowed to unmute if you want to share something. Okay, in the absence of anyone, let's understand self-harm. Just check, leaders, are these signs of self-harm? Cutting, burning or scalding oneself, head banging, breaking bones, punching the body, inserting, swallowing objects or poisons, throwing oneself against something. Are these signs of self-harm? What about smoking? What about tattoos? What about risk-taking behaviors? What about body piercings? These days, we are seeing different types of body piercings. What about eating disorders? What about alcohol use or drugs? I've noted your hand, my leader. Do you want to contribute? Please go ahead, Moni. Okay, my leader, Samsung SM A14 plus P. Sorry. You can go ahead. Are you able to unmute? Okay.
Oh, sorry about that. I was saying now, how will I draw a line or differentiate? Because some of these kids, especially when they are in this puberty or adolescent, they like to explore. At times,
Yeah.
they'll be doing things where thinking that it's not harmful. They just want to curiosity, you know, to see what will happen after. So how will I draw a line?
That's a very wonderful question, my leader. What is very important is when we actually talk to the young people and we ask them and we want to listen without being actually judgmental. And when they are comfortable enough and they are able to express what has been going on in their minds for them to do the various things that they are doing, we can actually then be able to draw the line to say, you know what, I can see that you are not just exploring, but here it's a form of, you know, self-inflicted harm. And when we talk to them and we create that environment of allowing them to express themselves, we are able to identify whether they will need further intervention. Have I tried to answer you, my leader?
Yes, yes. I think
Thank you
I
so much.
understand. Thank
Yeah.
you.
So the difference, it's mainly in understanding what the main cause of this, you know, self-harm behavior is, not just what they are doing. When they explain it, we are able to pick up that, in fact, here, there is actually self-harm. Okay. Now, we all do things that are harmful in some way. There is a difference between things that are harmful and self-harm. Intention is more important than the act or amount or severity of visible harm. Seek to clarify self-harm versus suicidal act. And it's much easier when a child has attempted suicide to see that, in fact, they wanted to end their life. But what about a child who did not do something that is that outrageous and yet they are harming themselves? Children and young people most at risk to themselves may be those who describe their mood in the least risky way. So you may find that they're doing something, and when they explain it, you know, it's something very light. They take it very simple. And that is a sign also that they don't realize, they have no insight into the danger that they are posing to themselves. And that sometimes also, we need to challenge the use of the word deliberate or dismissive terms like, you know, superficial or attention seeking. So at times, you know, when a child shows these kinds of traits, one will say, you know what, they're just attention seeking and that's why they're doing that. We need to really try to understand what is it that causes them. Now, young people may self-harm as a way to seek attention or to seek care or seek support from professionals or from parents or carers, because they aren't able to access it via any other route. And there are all sorts of reasons why young people self-harm, e.g., to feel something, to cope with difficult feelings, and also for a sense of control. They may actually inflict self-harm. Now, understanding the experience. Why do children and young people come to hospital in mental health crisis? Hospitals are not a very nice environment. And it is always not a first choice for young people experiencing mental health difficulties. However, they need professional care to stay safe, just like those attending with physical needs. When forced to seek medical care, they do so with feelings to shame and unworthiness. There are some voices that children may actually share. For example, look at the second paragraph. It says, I can understand their frustration at having to stitch someone up knowing that there is a possibility of them returning the next day with a new injury or after reopening the stitches. They're only human and have bad days just like everyone else. So this is a child who gets stitched and they just keep having injury after injury, or they undo the stitches. Another one of transfusion is the top one, where they say, I will not go up there anymore, mainly because I feel like it is such a time waster. And I hate all the questions they ask you. I just want to get back home, hide under the duvet and die of shame. I've ended up with some numerous infections. However, from not getting wounds treated. So you can see some of the voices of young people. There are positive and negative experiences of mental health support in acute hospital. And I want to highlight the issue of staff attitudes and behaviors. They have more impact on young people's experiences, and these are more important than a lack of knowledge around mental health. Negative experiences means young people are less able to cope when they leave hospital, and it encourages young people to abscond when attending due to their mental health problems. Now, what we also see is that children and adolescents' mental health services don't always get these things right either. The attitude of healthcare workers at times when they are dealing with young people, sometimes they may be a little bit challenging. And that's why it helps to have a multidisciplinary team, because as team workers, we are then able to actually tap into the needs of the child, and they end up having an overall good experience with the care that they have received. And the same goes for non-healthcare organizations, such as schools struggling to support young people in mental health difficulty. And it includes also our clubs. When you have more people who are involved, it helps, because some children may be more comfortable talking to another counselor than the actual teacher in the class, or talking to the deputy director than talking to the director, etc. So having a number of people who are caring, who have an understanding of mental health for our children is extremely important. And what is important as well is that children and young people who self-harm say that it is better experience when they can talk through what led up to the event. So it's contrary to popular belief that they don't want anyone, talking to them. And I have spoken to a number of young people myself within our clubs who have experienced various challenges. And in my own local church and also in the district, because when I notice something in a child, I don't become judgmental. I try to understand what they're actually going through. And what I find in most cases is that the child is also willing for me to communicate with a parent over an issue that actually is troublesome for them. These are very important leaders for us to keep our children in the ministry and to make them feel welcomed, to have a sense of belonging, and to thrive. The most positive encounters are where young people receive treatment as usual, that is non-discriminatory care, delivered with kindness and empathy, not just focusing on the physical aspects, if there are any physical aspects. So now, in closing, whilst there may be many perceived challenges to supporting children and young people with mental health difficulties, it is the small things that make the biggest difference. And what are some of those things? It's the care that we give to the children in our clubs. It is the compassion that we give to our children. It is the empathy. It is the validation, the reassurance, telling them that, you know what, it's going to be fine. Help is here. I'm here to listen. I will help you. I'll be here for you. That helps. And what is also important is allowing the child time to talk. All these things that healthcare workers are highly skilled and experienced in doing are things that you also leaders can do. Now remember, children and young people don't want someone perfect and scripted. So leaders embrace any form of awkwardness in your club. If there's a child that is different from other children, do not draw attention to the child in the whole club. But as a leader, take time to understand them, make sure that they are accommodated, make sure that they have a sense of belonging and they are assisted to actually do what is required in the club. Thank you so much, leaders. I don't know if there's any one or two questions and we can then close. Or even maybe one or two comments and then we can close. Thank you.
Thank
leaders.
you. Okay.
Oh, sorry.
No, you
Okay,
may
you can
speak
go.
now. Yeah. You may speak.
Oh, okay. Hi, I'm Moni Pasha from Shelo District, Leboahomo. I'm happy about this workshop because I also suffer from mental health illnesses. I have a major depressive disorder. So this is very, very, very important to our kids, and we thank our Congress for our conference for giving us this, because it's also a support to me also as a leader. And it's very challenging these days to know when children are being naughty or are self-harming. And I've just been discharged from a, a psych clinic, and I saw a lot of young people there, ranging from those teenagers. So, leaders, let's pray to God and help us to see and to be able to notify parents when they don't. Some parents don't know when their kids are having disorders and other mental problems or are depressed. So let's be a support to them. I thank you, my leader.
Thank you so much, my sister and my leader. Thank you for sharing that experience. And what I want us to also normalize is to actually normalize mental health like any other challenge. Some of us, we may be having mental health difficulties that are undiagnosed. And when they are diagnosed, they can be support. So we need to be open and we need to seek help and not feel that we are going to be stigmatized. Thank you so much, my leader, for sharing. Okay, my leader, Shimi?
Yes, sir. No, I was just trying to take the hands that were up. So I see Panashe's hand is also up. I was just facilitating that part for you.
Thank you, my leader.
Panashe, you may then go ahead then.
Okay, thank you very much. Mine is a question to say, what do you do in a situation where you're dealing with a child, who shows or who actually knows that they have some mental health issues, and now after assessing the child, you see that the causes or the triggers are the family where she's coming from, the parents included. And now you have to deal with this situation in, like you had said, whenever you see a child in such a situation, try to involve the parents, talking to them. But now the parents are the ones who are the main trigger. There is some abusive exercises that are being that are done to the child, and that's what's causing the mental health issues, or that's what's compromising the child's mental health, mental well-being. What do we do with such a situation?
Thank you so much, my leader, for that question. Now, let me also say, leaders, if there is anyone among us who has not done the child protection course that is offered by the conference, there is another opportunity coming for the child protection course. And why am I emphasizing this? It is because if as a leader you experience a sign of child abuse, or a child tells you of child abuse, the Children's Act and the Constitution of South Africa, which empowered the Children's Act, requires you as a leader to report such a matter. So it is very important that we then, assess issues carefully, and there are certain things that are beyond us. Like, for example, if we know that a child is being abused, our biggest responsibility is that of reporting. And where do we report to? We can report this to social workers who are dealing with children. We can report this also to our child protection coordinator, and we encourage our districts to also have child protection officers who will then be able to actually mobilize the different resources that we need within our districts for the different churches and so on to assist in such situations. So that one is a very tricky one, President Panashe. But everything that we do has to be for the best interest of the child. So even if we err on the side of the best interest of the child. Thank you so much.
Thank you very much. Sorry, just I actually had the second phase of the question. So, from the child protection, is it a child also needs yes the right to their own privacy? So you're dealing with a child with different types of leaders involved, and then the child manages to open up to you, open up their situation to you. And there are other leaders who are around and they do not understand the behavior of the child because the child is not yet opened up to them, and the child does not feel comfortable opening up to other leaders that you're working with. How then do we best make the other leaders aware of the situation, or just to make them, if I can say, tolerate the child in the way they are, without telling them exactly the situation of the child, since they say they don't feel comfortable with other people knowing their situation? I'm talking about leaders, not family.
Yeah, you know, that's why it's important to have the child protection officers and have other healthcare workers. For example, you know, there are no easy answers to these questions, leaders. But what the child protection course will actually train us is to know what to report, when to report, to whom do we make this reporting. And in this case, particularly where the child does not want you to share anything, it's important for you to constantly ensure that the child is aware that you have heard their situation and you are willing to assist. And this assistance may include anonymous reporting. Because, for example, if a child is young and they have experienced abuse, and there's a time where this issue comes or becomes a legal matter, and it is found out that you as a leader were aware of this situation, hey, it's a big problem. The law will hold us accountable. So we just need to be aware of that, President Panashe. It's important, honestly, to respect the view of the child, for this issue not to be investigated further or not for anyone to know it's just for your hearing, but also you have a responsibility to ensure that you support the child to be strong enough to seek intervention. And intervention is what will actually help the child in that situation. So it's not an easy thing, but we just need to do what is right for the best interest of the child. And it's not always, you know, black and white like that. Okay. Yeah. So we can talk about this maybe even outside of this platform, President, and also see, because if it's something that's happening in your club, we really need to see how best we can assist the child that is experiencing this problem. Otherwise, they may have serious mental injury. It may affect how they conduct themselves on a day-to-day basis as they grow up. Okay, thank you. I'm seeing there are 2 more hands, and maybe I think this may be the last 2 hands. I'm seeing the hand of...
Maybe we can take at yahoo.com. I don't know how to pronounce the name. tsangoni@yahoo.com, then Mone, then the Samsung was the last time that was up. Maybe we can have them in that order.
Thank you, my leader, and maybe they'll be the last hands. Thank you so much.
Good afternoon. Thank you for
Good afternoon,
this
my
wonderful. Thank you for this wonderful talk. I just wanted to ask, with regards to this is a beautiful presentation, sir. With regards to the awareness now, I wanted to find out if our Adventurer and Pathfinder curriculum has sort of awarenesses that we can, or even classes that we can incorporate about mental health. Yeah, something for us to make the children aware of this problem, that it exists and how to deal with it, you know, from our church point of view. Not for them to start learning about it at school, and yeah, so just for us to be ahead of them. I don't know if the leaders up there can come up with a sort of an awareness or a program that we can incorporate in the clubs. Yeah. And then lastly, I just wanted to allude to what you just said to President about the child who is asking you not to report. I work in the medical facility. I'm a doctor. It's required of you to report. Obviously, we need to find ways in which that it's not going to offend the child. Usually when you do this, you do it to the social. Obviously, I'm not very aware of the platforms that we use at the church, because I don't think the social workers are located, but obviously I stand to be corrected. You can start social worker, involve psychologists, also involve people that the child is willing to disclose to, because you might find that doesn't want you to tell everyone, but there's that one person that she's willing to disclose to, because should the law find out that you have been sitting on this big information, then you're also implicated. So I think it's always important to find ways of reporting and constant communication with a victim or the child who's affected, to find ways of helping them and making them aware. That's why I think it's important for us to have awareness and teach the children of the channels and how they are able to ask for help. Oh, and my name is Sakane. Sorry for not putting proper names when I joined.
Thank you so much, Doc, for that. And that's why also I'm very serious about mandatory reporting. It's mandatory. It's enforced by the Children's Act. And, you know, the issue of not reporting, the law does not have room for ignorance, saying I didn't know. If it is found out, leaders, that you knew about a child abuse case, whatever form of abuse that's really affecting the child, and we are quiet, we could find ourselves on the wrong side of the law. So as healthcare professionals, we are trained to really ensure that we report. And there are different interventions that can unfold from there. All right. So yeah, thanks, Doc, for that. And in terms of awareness, Doc, I just want to emphasize that we need to make use of the times we have at church. And the junior youth, the Adventist Junior Youth Ministry does not operate in isolation. We also have the Children Ministries Department. And when we work together as leaders, we could be able to bring about this awareness in our churches and talk about mental health challenges among children and adolescents. And in fact, right now, I take this as one of the introductory talks on mental health. There are other specific conditions that we can talk about that involve also mental health. So yeah, but this is just an overview, and it really helps us to see, leaders, that we need to break the stigma on mental health. It is the same as any other health condition. And the nice thing about a lot of these mental health conditions, if a child receives proper intervention early intervention is key. That child may be, let me use the word in code here, may be cured. There is that strong chance that the child may actually be cured, the child may be well, or the child may be controlled, and they don't have to have the symptoms, the signs and symptoms of the mental ailment that they are experiencing, because maybe they could be placed on medication, or they could be receiving some kind of psychotherapy and other medical interventions that are there to assist. So that's what we are here to say, leaders, to say help is available. Okay, thank you so much. The next hand, my leader.
The next code was Samsung SMA5.
Okay.
Oh, okay. I had raised up my hand and I put it down. Can I talk?
It's okay, my sister. I saw hand earlier.
Okay.
Oh, okay. Okay.
But I'm happy that the doctor, was it Sakani? Oh, I didn't hear the name well. He
Yes,
talked
Tsakani.
about illness. Yes, because I also have a child now. She's 2 and she was born with Down syndrome. Now it's a bit difficult because in like teaching them other things in the church, she's not yet speaking. She's still trying. Maybe she's got 5 vocabulary. And in my church, I've noticed that we also have kids with learning disorders.
Yeah.
And then I was wanting to know that how can we help them? Because with my child now, we're using some secular videos on YouTube, like Bo, Miss Rachel. That's how she's learning to express herself, how to ask and do what. Can't we have such visual aids for kids with learning disorders? Like I have one, and I wish to help her with growing in Christ than just knowing words and stuff, because others are learning about Christ, about Jesus and all. And I'm also a children ministries leader in my church, and I'm also manning adventures, and I'm having such a problem. And most of our club members, they are kids from the community. Their parents are not even in attending church with us. So I come across such challenges in teaching kids with learning disability.
Okay, thank you so much, my leader. You know, unfortunately, because of the time that we have, I will not be able to comprehensively answer. But what I can share with you is that my contact details are available. Please ask the president of your district to share with you my contact details. And I will find more support for you. There are resources in our church for children ministries that are very, very helpful. There are different ministries as well that also do some video clips that are informative or educative within their children ministries. And there are also some animations that you can actually view that can help with different types of mental illnesses and how to, you know, try and assist our children. Yeah, so there is help available, and I'll advise that maybe you should, we should talk outside of this platform. Thank you so much. Because learning disorders as well, there's a range and there are different types of learning disorders. And there are so many. and trying to address them now, I'll be doing an injustice. Thank you so much, my leader. But please, Sister Moni, talk to your leader. I can communicate with you outside of this platform as well. Thank you.
Can we take Samsung A14? I see there is another hand, Pumulo. Can we take Samsung A14?
Leaders, I want to tell you now, we are experiencing some heavy rain this side, and I'm not sure how it will affect us, but yeah, let's hear. Sister Pumulo?
Greetings, leaders. Greetings. This is
Yes.
Pumulo.
Okay, my leader, we can hear you. Greetings,
Okay, my leader, I'm having a concern on third-party reporting, where a child comes to you to say, "Am I audible?"
Yes, I'm struggling because of the rain, but I can hear you, my leader. You are saying you're having a problem on third party?
On third-party reporting, whereby a child comes with a concern to say, "My friend is being abused or is undergoing a form of abuse of 1, 2, 3, 4." Now, when I heard you very correctly, you said something about the Children's Act, and then the doc was telling us to say, if you find any abuse of some kind, you are obliged to report as a leader. Now, the challenge that comes in is to say, the child who is being abused is afraid to come forward because the perpetrator is threatening the child in some way. Now, this third-party information it's not the person, it's not the victim who is coming forward, but it's the friend of whom the victim has disclosed the information. Now, the fear that comes in here is to say, if as the leader I go straight forward and report without confirming to say the information is true, and then when the information has been reported, she comes in and says, no, that information is untrue. So now, if we act on third-party information, is it correct to say we can still withhold the information for a while and verify the information before reporting? Just wanted to be clear on that one. And then on the other thing, that once I, as the person, approaches the victim straight up, the victim withdraws themselves and they stop attending church, fearing to be interrogated. So in such a way, how do we go with such a case? Thank you.
Absolutely, my leader. And thank you for raising that, my leader Pumulo. What we are saying with Doc here is that reporting is mandatory, and we are not talking about third-party reporting because that is hearsay. And in fact, when you follow the reporting forms, when you do the reporting itself, there are forms that you complete, and they are very specific in as far as your first-hand experience is concerned with that particular child. You are required to provide as much detail as possible about the victim. So it is not third-party reporting. And I think it's important to look at it from that end. Otherwise, you are also completely correct. When one acts, it's not in our best interest to be the ones who are in the forefront of acting, because we may not be having the right tools. That's why reporting is also done, anonymously, without you, coming forward to saying, now I'm the one who has reported and I'm giving details. It's done anonymously. So yeah, I think I will leave it at that. But what I'll also encourage again, my leader, is for us to do the children's course. It's extremely important to do the child protection course. It has more details. The rain is now worse, and I see that one more hand. I don't know what to do.
I think the hand was a lazy hand. It's been up since. I don't think it needs to talk. It's been up. I want to believe it was when she spoke the first time.
Okay, thank you so much, my leader. I think that's about it for today.
Yes, sir.
Over to you, Sam.
All right. No, thank you, Doc, for the presentation. Personally, I know it has been edifying, and I hope with everyone that has joined, it has been edifying to us, and we'll be able to share the information. We'll be able to deal with such cases in our various ministries. So we do thank you for that. In closing, I will therefore ask, I can see there's a Pindi Lengwenya. May I ask Pindi Lengwenya to close in prayer for us? Pindi Lengwenya to close in prayer for us.
Okay, let's pray, my leaders. Our kind and heavenly Father, we thank you, Baba, for isikhathi osipesona singama leader. Sibonga Nkosi imfundiso osiphe yona, ulwazi Nkosi osithe washirela lona. Sicela ke Nkosi ukuthi sikwazi ukulithatha Nkosi silisebenzise emabandleni wethu ukuze Nkosi sivikele abantwana Nkosi osiphe bona ukuthi sibahole. We ask that you bless the presenter and you bless us as leaders as we go and preach the gospel to our kids. Ibanathi ke Nkosi usenzele konke singakhona ukuzenzela kona ngoJesu Kristu Nkosi yethu.